Welcome back to the Great Adventure, Pediatric Pulmonary Physiology. This is session number 16 out of 30, and today we're going to talk about the pulmonary circulation and in defense of the lung. So this is the Great Adventure. Here we are through the series here, and we want to approach this with the enthusiasm of a child in a candy shop. Remembering about gas exchange for a moment. Remember, gas exchange is determined by VQ. The alveolar O2 and CO2 is determined by VQ. Normal is 1. VQ ratio greater than 1 gives us increased oxygen, decreased CO2, and a VQ ratio less than 1 gives us decreased oxygen and increased CO2. The distribution of ventilation is determined really by only two things: decreased distensibility, so you can see most inspired air is going to go here, less is going to go to this stiff lung, or airway obstruction. Most of the inspired air is going to go here, less is going to go through this narrow airway. So I want to talk about two things that we haven't really discussed: the pulmonary circulation and in defense of the lung. And when we're talking about this, we're really going to talk about just some mechanical sorts of things, not immunologic. All of you know, this is the wimpy heart, by the way. All of you know that unoxygenated blood returns from the body in systemic veins in the right atrium, right ventricle, goes out through the pulmonary artery to the lungs to be oxygenated. Oxygenated blood then comes back through pulmonary veins in the left atrium, goes to the left ventricle and out through the aorta and other systemic arteries to oxygenate blood in the body. So basically, pulmonary arteries follow airways in the pulmonary circulation. Right, so as airways go down and bifurcate, pulmonary arteries follow those airways and bifurcate as well. As opposed to the systemic circulation, the pulmonary circulation is a low pressure, low resistance, high compliance circuit. Pulmonary vascular resistance is extremely low, only about 10% of systemic vascular resistance. And low pulmonary vascular resistance is maintained despite increased cardiac output. Here we have an example of cardiac output increasing. So this might be cardiac output at rest. This might be cardiac output at maximal exercise. And you can see that pulmonary artery pressure does increase some, but not as much as cardiac output increases. So for a 5 times increase in cardiac output, you have maybe a 2 times increase in pulmonary artery pressure. If, in fact, the pulmonary circulation was rigid tubes that could not expand, right, and you tried to increase cardiac output 5 times, you'd have to increase pressure probably at least 5 times, and the wimpy heart probably couldn't sustain that. The other thing about the heart is that, or about pulmonary circulation, is that as cardiac output increases, pulmonary vascular resistance actually falls. Okay, so there is something about the pulmonary circulation that when more blood goes through it, it actually falls. And this is exactly what happens. So if this is the pulmonary capillaries, kind of depicted here in an upright person at rest, we've talked about the fact that there is zone 1 of pulmonary perfusion, that is, that our alveolar pressure is greater than both pulmonary artery and venous pressure up here, and there's no flow. As we go down, pulmonary artery and venous pressure increase, exceed arterial pressure, alveolar pressure, and then capillaries gradually increase in caliber. With exercise, since pulmonary artery pressure increases, all of these vessels that were once closed now open. So these are said to be recruited, and the ones that were open dilate even further. So the pulmonary vasculature, specifically the pulmonary capillaries, but the pulmonary vasculature increases its total cross-sectional area by both opening up capillaries that were previously closed and dilating capillaries that were previously open. So the total cross-sectional area now is going to increase, which means that a larger flow can go through without increasing pressures so dramatically. If we look at the effects of lung volume on blood vessels, so there are extra alveolar blood vessels, and these are pulmonary arteries and veins, and they are subjected primarily to pleural pressures. So at increased lung volume, okay, pleural pressures, which become more negative, distend vessels, decreasing pulmonary vascular resistance, as shown here. So these larger vessels have a decreased resistance. At decreased lung volume, pulmonary pressures pleural pressures, excuse me, become more positive and in fact compress vessels, increasing pulmonary vascular resistance. There are also intra-alveolar vessels, and these act very much like Chinese finger traps. So these are pulmonary capillaries. They're subjected primarily to alveolar pressures. So at increased lung volume, the stretch on alveoli compresses capillaries, increasing resistance. So just like these finger traps, if you put your fingers in and pull, they collapse on your finger and essentially decrease in caliber. At decreased lung volume, alveolar pressure decreases, distending capillaries and decreasing pulmonary vascular resistance. So with these traps, again, you put your fingers closer together, they enlarge, and you can pull your fingers out. So the pulmonary capillaries, intraalveolar vessels, work exactly like these Chinese finger traps. So for more than one resistance in series, resistances are additive. So for example, total pulmonary vascular resistance would be equal to the resistance in extraalveolar vessels plus the resistance in intraalveolar vessels. For more than one resistance in parallel, reciprocals of resistance are additive. For example, if we wanted to look at resistance of airways in the right lung and the left lung, all right, that total vascular resistance, the reciprocal of the total would equal the reciprocal of the right plus the reciprocal of the left. When we're dealing with extra and intraalveolar pressures, however, or vessels, however, these are in series. That is, blood goes through one after the other. They go through the pulmonary artery, extraalveolar vessel, then the pulmonary capillary, intraalveolar vessel, then the pulmonary vein, extraalveolar vessel. So the resistance are going to be additive. So extraalveolar vessels, remember, had the lowest resistance when they were distended at high lung volumes. And as you decrease lung volumes, they're going to have higher resistance. Intraalveolar vessels were the opposite. At low lung volumes, alveolar pressures do not compress these vessels, but this increases as you increase lung volume. So total pulmonary vascular resistance is the sum, and look what we have here. If we sum these, the sum of total vascular resistance is the lowest at FRC, which is where you live. So pulmonary vascular resistance is lowest where we spend our life at FRC. There are a number of things that can cause vasodilatation, oxygen, nitrogen oxide, number of medications. There are also things that can be vasoconstrictors. The most important are hypoxia and hypercapnia, acidosis perhaps, and some medications. Pulmonary vascular resistance at the local level, the alveolar level, is determined by alveolar PO2, not arterial, alveolar PO2. And what happens is that for an alveolar PO2 down to about 60, there's no change in pulmonary vascular resistance. Below 60, pulmonary vascular resistance increases exponentially. So why is this happening? What would be the benefit of this? So if we have an area of lung that has decreased alveolar ventilation and consequently decreased VQ, it's going to have decreased oxygen, right? So what's this going to do? Basically, what it's going to do is constrict this blood vessel, right? So when that happens, you now have decreased blood flow to areas where there's decreased alveolar ventilation, and you have relatively preserved VQ and relatively preserved arterial oxygen, alveolar oxygen concentration. So basically, this locally needed reflex basically looks at the alveolus and says, I'm hypoxic, there's too little ventilation, there's too much blood flow going in here. We should try and decrease the blood flow to match the amount of ventilation. So this is a protective mechanism. There is also fluid exchange in pulmonary capillaries. So the alveolar capillary membrane is porous. There's an electron micrograph of an alveolus, epithelial layer, interstitial layer of fluid, usually a virtual space, endothelial layer, and then the red blood cell. And we talked in the beginning how the lung is designed in a way that the entire cardiac output is spread out one erythrocyte thick through the pulmonary circulation. So fluid exchange can occur across this membrane. In the lungs, we want fluid to remain in the capillary, not in the alveolus. So what forces keep fluid in the pulmonary capillaries? Colored osmotic pressure of plasma tends to keep fluid in the capillary. Alveolar pressure tends to press fluid in the capillary. On the other hand, capillary hydrostatic pressure tends to move fluid out of the capillary into the alveolus, and increased alveolar surface tension can also suck fluid out of the pulmonary capillary into the alveolus. Fluid exchange. Increased capillary hydrostatic pressure pushes fluid into the interstitial space, and this causes stiff lungs. A significant increase in capillary hydrostatic pressure pushes fluid out even into the alveoli, causing pulmonary edema. So what's the cause of increased capillary hydrostatic pressure? It's generally the wimpy heart. If the left heart fails, it backs up blood into the pulmonary circulation, increasing pulmonary capillary pressure and causing either interstitial edema, which causes stiff lungs, and or outright pulmonary edema. So we've now talked about lymphatics. Fluid is cleared from the interstitial space by lymphatics. Pulmonary lymphatics drain through the hilum to the thoracic duct to the superior vena cava. Right, so basically the situation is like this in tissues, including the lung. Right, so we have blood coming from venous through capillary bed to the arterial end, but some fluid eventually leaks out into tissue, and this is taken up by the lymphatic system. Right, and the lymphatic system basically is kind of a loose network of vessels that basically collect, go to the thoracic duct, and eventually empty into the left subclavian vein. Excuse me. This is just another way. So you've got arteries here, you've got a capillary bed, venous here. So these kind of wrap around the capillary bed and collect interstitial fluid into lymphatic vessels, which eventually go out of the thoracic duct into systemic veins. So pulmonary edema and heart failure. Everybody knows that left heart failure causes pulmonary edema. Blood backs up from the left ventricle into the lungs, it increases pulmonary capillary pressure, and you can get edema. What is less common is that right heart failure can also cause pulmonary edema. In this case, blood backs up from the right ventricle into systemic veins, and this is going to decrease thoracic blood duct flow, which is going to decrease thoracic fluid clearance. So right heart failure can also cause pulmonary edema. When you see pulmonary edema, it does not automatically mean that you have isolated left heart failure. Right heart failure, even isolated, can also cause pulmonary edema by restricting or decreasing or impeding thoracic duct flow and pulmonary fluid clearance. So a clinical law, whenever the wimpy heart fails, it takes it out on the majestic and elegant lungs. And I think you've already seen this. Right or left heart failure can cause edema. When the wimpy heart fails, it takes it out on the lungs. Is there an effect on lung mechanics of fluid backing up into lungs from a dysfunctional heart? Is it only making lungs stiffer, or can it affect airway function? If so, is there a role for diuretics in lung diseases not classically considered to be obstructive? So Lilikow, who was a postdoctoral fellow in neonatal perinatal medicine here at Children's Hospital Los Angeles, 1981 to 83, did a couple of important studies. So she gave diuretics or placebo to babies with bronchopulmonary dysplasia and measured their pulmonary mechanics. So she had a baseline measure, measured time zero when the diuretics were given, and then measures at about 30 minutes, 1, 2, 4, 6, and 24 hours after a single dose, in this case, of Lasix given IV. This shows what happened. So this is urine output. And you can see from the placebo there was no change in urine output, but with diuretics there obviously was an increase in urine output up to about 6 hours when it returned to be not significantly different. This is thoracic gas volume, or FRC, which really was not much difference between diuretics and placebos after receiving a diuretic. This was dynamic pulmonary compliance. And you can see that those infants that received a diuretic had a 50% increase in dynamic compliance at about 1 hour uh, fell off by about 4 hours, still increased at 2. The other thing that was interesting was that airway resistance also decreased, again, in this case by about 40% at 1 hour following diuretics and not really after placebo. So airway resistance also improved following a diuretic. And specific airway conductance, which remember is the reciprocal of resistance divided by the FRC it was measured at, also increased by 80% 1 hour after diuretic and was still up 4 to 6 hours after a diuretic. So diuretics acutely can improve both compliance and resistance. What about chronically? So this was kind of a nice experimental design where a number of infants were treated in a crossover manner with a long-acting diuretic, in this case a chlorothiazide and a potassium-sparing weak diuretic spironolactone. And they were given this for a period of time followed by a control period or the other way around. So the order was randomized. And basically, what was plotted here in this statistical technique is whether there was positive change favored diuretics. So all of the patients actually showed a positive change with diuretics. And once this line crossed this sort of boomerang shaped thing here, it was statistically significant and the test study could be stopped. So here's what happened. First of all, this is weight gain. Basically, not too surprising. The kids on diuretics lost a little bit of weight, but this was regained fairly quickly. This and of course the placebo group did not have a change. This was and this is weight or weight gain. Excuse me. This individual started with on the placebo arm and then lost some weight with the diuretic, but that was regained. So this is thoracic gas volume. And what's plotted here again is the one group did placebo first, then diuretic. The other group did diuretic first, then placebo. There really is no effect on diuretic. This is dynamic compliance. And you can see that the group that started with the diuretic, dynamic compliance increased, and this is absolute values now. So that's about a 33% increase. And with placebo, this fell. With the group that started with placebo, no change, but with diuretics, they improved. So significant improvement with diuretics. This is airway resistance. So the group that started with diuretics had a drop in airway resistance. It returned to normal on placebo. The group that started with placebo essentially had no change and then a drop with diuretics. So diuretics had a significant effect. And then finally, specific airway conductance. The group on diuretics, it increased, fell back on placebo, started on placebo, no effect, and increased on diuretics. So bronchopulmonary dysplasia has pulmonary edema. Pulmonary edema causes decreased pulmonary compliance, but it also increases airway resistance. And diuretics, both acutely and chronically, improve both compliance and airway resistance in these babies. Now let's talk about in defense of the lung. So here in Southern California and actually throughout much of the West, recently we've been having large fires. Some examples seen here. And these really muck up the air. So if you're outside breathing this, your lungs are exposed to this foreign material, which potentially could cause damage. So the lungs are directly exposed to the environment. How does it protect itself? Inhaled particles, chemicals, or organisms can cause damage to the lungs. So how does the lung protect itself? What materials get into the lung and where do they go? So it turns out that one of the major answers is airway size. Large particles really don't get down in the lungs. They're pretty much trapped in the nasal cavity. Smaller particles get in large airways, but not further. Smaller particles further down. And the smallest particles get all the way down. Let's just look at that in some detail here. So heavier particles greater than 10 microns in diameter. You remember from physics, force equals mass times acceleration. So these particles are going to tend to move in a straight line. It's going to take a lot of force, all right, to change the direction of this particle to go down the airway. So these will not accelerate, change direction, and follow the airway, and most of these will impact on the large airway. So Those who have been in areas with a lot of this kind of air pollution, these are actually big particles of smoke, for example, and they don't really get into your lungs for the most part. I don't want to be crude, but if you blow your nose in this situation, it comes out black because that's where most of the soot was. It stayed up here and didn't really get down into your lungs. Airflow is both laminar and turbulent. We've talked about that before. One thing about turbulent airflow is if this is carrying materials, these turbulent airways basically throw these materials onto the airway surface or impact on the airway surface. So middle-sized airways, or middle-sized particles, 2 to 10 microns in diameter, are carried in turbulent flow in large airways, and they sediment out in these turbulent airways. 5 to 10 micron particles deposit in the trachea and large airways. 2 to 5 micron particles deposit down in bronchioles or smaller airways. Small sized particles, less than 2 micron, are carried in airflow all the way out to respiratory bronchioles and alveoli, and their final mechanism of deposition is by diffusion. So basically, to summarize, large particles are deposited primarily in the nasopharynx by impaction, smaller particles, trachea and bronchi, by sedimentation, respiratory bronchial sedimentation and diffusion, and finally alveoli by diffusion. Some very small particles are actually exhaled back out. So the lungs connect with the environment, permitting the delivery of medications by inhalation. One nice thing about being a pulmonary physician is that we have another way of delivering medications by inhalation, such that it gets in the lung in relatively high dose, but doesn't get out to the rest of the body where it causes side effects. So these medications can be delivered by wet nebulizer aerosols, metered-dose inhalers, or dry powder inhalers, and the size of the particle determines where the medication goes in the lung. So these are examples of wet nebulizers. So this is an interesting study. So this group, Omar and his group, did a study where they took inhaled short-acting beta agonist particles, right? They tagged them with radioactivity, probably technetium-99. And so here is the entire lung field, okay, that these particles could be distributed to, all right? And what we're going to look at is where they went and the effect on FEV1. So red indicates where most of the deposition is, blue indicates where little of it is. So a 1.5 micron particle, one would expect would get out to the relatively small airways. And I think you can see that it pretty much fills the entire lung field here. There is a little bit more central deposition, but it's out here pretty much throughout. And its effect on FEV1 mean was an increase of 337 mLs, right? A slightly larger particle, double that size, is more into airways, less in the periphery here. And you can see that it was, because it was focused in airways with smooth muscle, it increased the FEV1 by 420 mLs. And finally, the largest particles, 6, which are going to deposit in bronchi and bronchioles, all right, basically deposited here centrally, as you see, and they increase the FEV1 the most. If you're a pharmaceutical company, by designing the size of inhaled particles, you can determine where it's going to go in the lungs, that is, what size airways. Metered-dose inhalers shown here with or without spacers. And this just shows an example of the mass median aerodynamic diameter of an MDI medication, in this case an inhaled steroid, is around 4 microns. So that means it's going to get where you want it, into the middle-sized airways generally, but of course there is some variation, so it'll hit large airways and a bit smaller as well. So larger particles impacting the upper airway and do not reach the lung. Particles removed from large airways are removed from large airways by cough. Particles are removed from bronchioles by mucociliary activity, and particles are removed from alveoli by alveolar macrophages. So let's explore some of these. So this is a cough. So what happens when you cough? Something stimulates cough receptors in your airways. You take a deep inspiration, you close your glottis, you build up a high intrathoracic pressure, you compress this, and then you release your glottis, and that brings out flow at the highest flow rates of anything people do. Okay? So that's what a cough is. In the trachea, About 3/4 of it are surrounded by cartilage, but about 1/4 by the so-called pars membrana. And this can involute inward. When it does that, the total cross-sectional area of the trachea decreases, which means the speed or velocity of air molecules increases. So you now have a very, very fast or high speed sort of exhalation of air particles that can clear particles from this airway by shear stress. So it clears, the cough clears large airways of secretions by high velocity gas volume. And this is the primary mechanism for secretion removal in large airways. So how fast does flow go in your trachea? So air velocity in your trachea with breathing normally is about 15 to 20 miles an hour. You could power this sailboat if you had enough. If you want to blow out the candles in your birthday cake, or certainly if you want to blow out the candles on my birthday cake, you generate hurricane force winds in your trachea, 150 miles an hour. All right, you can do that. And then if you do a compressed cough, the air velocity in your trachea when you cough is 85% the speed of sound, roughly 647 miles per hour. Phenomenal. The heart can't do that, but the lungs can do this very easily. And this just plot just shows these values specifically. So cough receptors, where are they located? So they're located in the nasopharynx. Anyone who has a cold can tell you that. Located in the back of the throat. They're located in the large airways, trachea and bronchi. They are not located in the parenchyma of the lungs, alveoli, etc. They're located in the esophagus, okay, and in the stomach. Anyone who's eaten a heavy meal and maybe had some alcohol with it knows that that night one might have heartburn or esophageal reflux. But one of the other things that happens when you do that is that you cough. So cough receptors in the airways, but not in the periphery of the lung. So an ineffective cough, abnormalities or alterations in cough reflex, are unresponsive to repeated stimuli. So you get habituation of a cough. Anyone who's had a cold knows that the worst cough is in the beginning, and as the cold continues, that cough tends to subside. Part of the reason for that is that your receptors kind of downregulate and don't respond to the same irritation anymore. Receptors are not present in alveoli or lung parenchyma. They can be suppressed by CNS depressant medications. And of course, neuromuscular diseases don't affect the cough reflex, but affect one's ability to generate a forced pressure. Laryngeal abnormalities preventing glottic closure can also cause an ineffective cough. Now, cough is important. We want to remember that you want a cough to be able to remove secretion. Things that can inhibit a cough, codeine, dextromethorphan, ipratropium, other medications. Hypertonic saline certainly can stimulate a cough, terbutaline, and chest physiotherapy. So in middle-sized airways, we have mucociliary clearance, which is the main thing that moves materials from the lung. So John Wong, who did his master's uh, science thesis at the University of Toronto when I was a fellow, I actually collaborated with him. This is from his thesis, and it's just a depiction of mucociliary activity. So we have airway epithelial cells, we have cilia. These generally are functioning in an airway surface fluid layer, shown here, so that cilia can beat and mucus floats on top of that, and that in a normal situation, this is moved upward and out toward the mouth. This just shows another picture there of mucus glands, which secrete mucus that float on this airway surface fluid layer, and the cilia actually beat in this fashion. They hook here under the mucus, move it this way, and kind of recoil and go again. Cilia beat about 600, 900 times a minute, or 10 to 15 hertz. They're small, their diameter is about 1/4 of a micron, and length about 5 to 8 microns. We now know that there are some genetic disorders of cilia where some of these dynean arms, so-called, can be missing, such that these cilia, which act like muscle, really actin and myosin, crossing each other, do not work. And patients that have primary ciliary dyskinesia have problems with repeat lung infections, sinus infections, and so on, because the cilia are meant to clear bacteria and other materials. This shows an electron micrograph of cilia. This is that airway surface layer, mucus on top of it, and you can see here that there are little hooks on this cilia, which actually hook that mucus and move it along when the cilia beat. Pictures of how this mucus blanket theoretically looks over cilia and a mucus gland secreting some mucus. So basically then the situation normally is you've got cilia, they're in this airway surface fluid layer, they kind of recoil, hook onto the mucus and move it forward and then kind of counteract like this. So a disease, cystic fibrosis, that we deal with is due to abnormalities in this whole mechanism. So normally you have a protein called CFTR, which basically is a chloride pump. So it pumps chloride out of the cell into this surface layer. Water follows by osmosis, as does sodium. And so you generate this airway surface fluid layer where mucus can beat, and relatively thin hydrated mucus floats on top of that. So if you have cystic fibrosis, the CFTR does not function, and so chloride is not pumped into the airway surface fluid layer. Mucus, in fact, is thick and dehydrated and viscid. Water is reabsorbed, and the mucus gets kind of gummed up in this whole thing and does not function. So this is just an example of how this all works. So we're now going into the lungs here. And what you have in the normal airway surface fluid layer is shown here. So you have this airway epithelial cell, you have cilia that's moving. You need this airway surface fluid layer in order for cilia to have room, and a relatively thin mucus floats on top of that. This is all made possible because CFTR is pumping chloride out of the cell and water is following by osmosis. Right, and again, what's important here with respect to CF is the fact that CFTR is pumping chloride and water so that you can get this surface fluid layer. Now, if you have cystic fibrosis, there's a problem with CFTR. It does not pump chloride out. Water does not follow, right? And therefore, the situation that we have in the lungs is that you don't have this airway surface fluid layer. It contracts, and the mucus becomes thick and viscid and difficult to cough out. So consequently, this really is not moving at all. So that's the problem in cystic fibrosis, and that's a, a problem with mucociliary clearance, but not specifically with the cilia themselves, but with the transport of water and electrolytes into that area. So things that can thin mucus, mucomist, DNase, hypertonic saline, things that can increase mucus viscosity, infection, cystic fibrosis, dehydration, chloride channel abnormalities. When we treat cystic fibrosis or primary ciliary dyskinesia or other problems where the mucociliary apparatus does not work, we basically use what I call the ketchup bottle model of the lung. And that is, if you want ketchup out of a bottle, you turn it upside down and pound on it. And that's literally what we used to do, as shown here. Now we have devices such as high-frequency chest compression vests that can do the same thing, can basically, they're pneumatic vests that can move the mucus out. And studies have shown that one has just as much airway clearance with a vest as you do with traditional physiotherapy. So how can you tell if a vest works as well as traditional CPT? Airway clearance is designed to move mucus from small to middle-sized airways into large airways where mucociliary clearance, when mucociliary clearance is defective. Okay. Thus, effective airway clearance should improve lung function and produce similar amounts of mucus. So Ron Ahrens, who was a postdoctoral fellow in pediatric pulmonary at Children's from 1991 to 95, actually did a study where he looked at the effect of the high-frequency chest compression vest versus traditional chest physiotherapy on 25 in each group, actually, children admitted to the hospital for a 2-week IV treatment course of their acute pulmonary exacerbation of cystic fibrosis. The age here, as you can see, they were a little older, around 20 average. Males, females, not significantly different. BMI about the same. Baseline lung function was not significantly different, including slope of phase 3, which was elevated, and they were significantly hyperinflated. These subjects were randomized to get 4 treatments a day of high-frequency chest compression vest or traditional chest physiotherapy. All right. And so this is increase in vital capacity. And you can see red is the vest, blue is the CPT. No significant difference, all right, at 7 days and at 14 days. So this halfway through the admission, at the end of the admission. Increase in FEV1, again, not significantly different. If anything, the vest seemed a little bit better. FF2575, again, not significantly different at 7 and 14 days. And decrease in residual volume, again, not significantly different. Decrease in RVGLC, not significantly different between the vest and CPT, and decrease in slope of phase 3, which is a measured distribution of ventilation, as you know, not significantly different at 7 and 14 days. He also measured the sputum wet weight in terms of grams over a 1-hour period and a 24-hour period, and there was a significantly increased amount of sweat at 1 hour, sputum at 1 hour with the vest compared to the CPT, but there was no difference that was significant, at least at 24 hours. This was sputum dry weight, and there was really no difference between the vest or chest PT at 1 hour or 24 hours. The high frequency chest compression vest and chest PT are equally effective and safe during hospitalization for an acute pulmonary exacerbation of CF lung disease. And we speculated at the time that the vest may provide an adequate alternative to chest PT in the management of CF patients in a hospital setting. And of course, now in the US at least, the vest is far and away the most common or popular form of airway clearance in use. Can we measure how fast mucus moves by mucociliary action? And if so, what is the effect of gravity on mucociliary action? And does it differ in CF patients versus normal controls? So this is the Hospital for Sick Children, Toronto, the golden era when we were there, 1977, the 100th or 75, the 100th anniversary of the hospital. And this is John Wong and me during that time. And John was the person who did, I think, a really brilliant study. We wanted to measure what we referred to as mucociliary tracheal transport rates. This is how fast mucociliary clearance actually moves particles in the trachea. So what we did was we had individuals inhale large radioactively tagged albumin particles, 10 microns. So that means these are going to impact in the large airway, at the larynx, and perhaps down at the carina. A little bit beyond that, okay? Radioactive tagged. So what we did was, if you put somebody against a nuclear medicine camera, what you saw was a spike of radioactivity at the larynx, where a bunch of particles deposited, and a spike of radioactivity at the carina, where a bunch of particles spiked. And then every once in a while, mucociliary activity would take a glop of radioactive mucus here and move it up the airway. Okay, now this is the trachea, so there's only one airway, so we're not confusing with several others, and we could actually track how fast this thing was moving. And that gave us an opportunity to actually calculate or measure the mucociliary tracheal transport rate, that is, how fast mucociliary clearance was actually moving things along the trachea. And we did this in an upright position and in a head down position because we were interested in the effect of gravity. The head down position at 25 degrees, the problem is people had to stay here for roughly an hour or so in each position. And this is about as much as most of us could stand, was a 25-degree head down position. So here's a normal subject. So this mucociliary tracheal transport rate is in millimeters per minute, all right? And that's the slope of this line, distance versus time. And you can see, so about 2 millimeters a minute is the average tracheal transport rate in a normal subject in the upright position. Head down, there's actually no change. The rate, maybe it's up a little bit, but it's basically pretty consistent. So what this says is that mucociliary clearance is more important than gravity in terms of moving foreign materials out of the lungs. This is a patient with cystic fibrosis. And you can see here, this material is actually moving downward. And then C means to remove by a cough. Here's another one moving downward. We now put this kid head down, and you can see that it looks like the normal. It's moving out. Removed by cough again, upright again, and it's moving down. Another patient, in this case, a little weird. It went up for a while, then it just kind of hung around the same place for a while. Started to slide down. We move him head down, and then moves out, like you would expect in a normal subject. So in CF, in the absence of mucociliary clearance, gravity has the most effect, and you can see that here. Normal individual, there's really no difference between upright and gravity, head down. But in the CF patients, there is a significant difference, a lot more variability, but the clearance is a lot more in the head down position, meaning the gravity has an effect. So one of the more interesting aspects of this experiment was this. So this was one of our pulmonary technicians who served as a subject, and this was what we got. Looked like he has CF, right? This, mucociliary clearance clearly not working. You put his head down and it works again. Gravity more than mucociliary clearance, so this is not working. So he did not, in fact, have CF, but what he did have was a viral respiratory infection about a week before this study. He didn't tell us about it. He wasn't particularly concerned about it, and he was not symptomatic at this point in time. But when we repeated this 6 weeks later, after an acute viral respiratory infection, you can see that his pattern is entirely normal. What's interesting is that mucociliary clearance is fragile, and even a otherwise modest viral respiratory infection can completely knock it out. So, traditional airway clearance therapy, percussion pulse drainage, or the vest moves secretions from all small airways into large airways. Secretions are removed from large airways by cough. If someone has a poor cough, i.e., someone with neuromuscular disease, we can add a cough assist device or some other cough assist maneuvers or technology to remove secretions from the large airways. And patients with a poor cough need airway clearance and a cough assist device, not just one. So, what have we learned? The pulmonary circulation is a low pressure, low resistance, high compliance circuit. Pulmonary vascular resistance is extremely low, about 10% of systemic vascular resistance. And low pulmonary vascular resistance is maintained despite increased cardiac output. P-alveolar O2 is the most important determinant of pulmonary vascular resistance, and hypoxia increases pulmonary vascular resistance. We also learned larger particles that are inhaled and packed in the upper airway and do not reach the lung. Particles removed from large airways by cough, particles are removed from bronchioles by mucociliary activity, and particles are removed from alveoli by alveolar macrophages. So, to this point in time, we've talked about gas exchange, which is determined primarily by VQ, as you know, and two aspects of lung function that determine the distribution of ventilation. We're now going to move on to other parts of the respiratory system outside the lungs, and next time we're going to talk about ventilatory muscle function, part one. So we will be talking about how ventilatory muscles affect lung function, respiratory failure, and a number of other issues. Thanks again to producer director Katie Lewinter, and thank you so much for joining the great adventure, Pediatric Pulmonary Physiology.